Okay, hello everyone. So we're gonna start with today the seminar will be basically focusing on the imaging method. So we're gonna talk about X-ray, CT, ultrasound, and MRI. And we're gonna just give some example and some specifics that we think that's important and they can use it as a saving question. So we're gonna start with X-ray. So X-ray is a high electromagnetic energy. The machine basically composed of electricity source, X-ray tube, control panels, shutters, and device of visualization. As you see, this is the X-ray machine, and we have two positions when we describe the picture, which the most used one is the upright position, and the supine position mainly used for a patient that are immobile. Can we go to the next one? Okay. So the principle of X-ray is basically based on the X-ray tube. As we see in the picture, we have this X-ray tube that composed of cathode, a anode, and a vacuum. The cathode is the negative charge where the electrons are created by a process called thermoionic emission. So in the cathode itself, there's a filaments that called tungsten filaments. And these filaments have features that allow them to resist and to stay for a long time without damaging. So they have high electrical resistance. They are very thin that they can recoil a lot and create a high surface to create more electrons. The melting point is high and they have high atomic number. And in the vacuum, as we know, it allows the electrons to pass without any interfering. And then we have the anode, which is the positive charge, which will absorb the electrons, and it will feature them as an X-ray image. So in how all this process occur. So we will give an electrical current, and this electrical current will run through the tungsten filaments. They will heat up the filaments and they will create heat energy. And this heat energy will allow the valence electron to become excited, if you remember from physics. So like you give an energy, we will excite the electrons, it go up to higher position and it will release an energy and a photon. And this will lead to release an energy and electrons. And these electrons and this whole process is called thermoionic emission. Then these electrons will be accelerated in the vacuum and then will hit the anode. When they hit the anode, their kinetic energy will be transferred to 99% to heat and 1% into X-ray, which will produce the image. Malaz? Can we skip to the next? There's another a component, the X-ray shutters. We have a primary one and secondary one. The primary is between the X-ray tube and the patient, and this one will regulate the radiation regulation of the radiation. This will control the size and the area that undergo radiation. And the secondary one is between the patient and the image visualization device, which will eliminate the scattered secondary radiation and allow a fine picture to appear. So like if you see here that, okay. And fine, okay. If you see like this is like the X-ray tube in the up, and this is like the red one is the primary shutter, which will focus the size of radiation we want on the patient. Like you can change it. And then we have this, the blue one is the patient, and the secondary shutter uh, will eliminate any scattered light that we don't want and would only focus the X-rays beams that we want to form on the X-ray film. We can go to the next one. Then and we have detectors which will detect the X-ray. So we have X-ray film and digital detector. So the X-ray film is made of a silver bromide, and this silver bromide will undergo reduction to create a black color based on a photochemical effect. So I don't know if they explain it in the class, or we should go into deep about the photochemical, but I will talk a bit about it. So we have when the silver bromide are exposed to X-ray, the bromide ions will release an electron and become bromide, and the electrons will gonna get attracted to the silver crystal. So more and more electrons will get attracted to the silver ion and attach to the silver crystal to form a silver atom. And in order to form an image, we need 6 silver atoms, and we have like metallic, and will create a black image. But I don't think you need to know this deep in the final. The only thing to know is silver bromide will undergo reduction and create a black color. So if it's low absorbed tissue, we will have more radiation pass through the tissue, and we have more silver reduction, so it's going to be more black, like gas, air, wood, plastic, all these we're gonna see it on X-ray as a black. Then we have high absorbing tissue, so less radiation will pass through it, and low silver reduction, so low to no black, as we say, white or opacity. And we're gonna see it in bones, calcified tissue, metal, and fluid. The second detector, we have the digital one. We have the direct and the indirect. So the direct, we have the X-beam interact with the phosphorus layer on the detector cassette, which have the same, what is it in English? Like the same as the process of photochemical effect. And we will have a laser scanner, but in this one, we will have no X-ray film. Then we have the direct, which we see the picture immediately on the computer. There's no X-ray film and no cassette. We can go to next. So what we see in X-ray, as we see here, we have a normal finding of an X-ray. And can you tell me if this is a female or a male of X-ray? Okay, yeah, it's correct. It's a female X-ray. And what we see in a normal findings. This is a posterior interior X-ray of an adult. It's written female patient. And we can see the lung volumes. We can see the cardiac silhouette. What is a silhouette? Is the edges of a structure that are seen when they interfere with a different structure with a different density. So like as you see, this is the lungs where they appear black because lungs are filled with air, so they have a higher absorption, so it will appear as black. But the heart, as we see here, it appear like more white. Then so we can see the edges of the heart comparing to the lung because both of them have a different densities. We can see that a costophrenic sulci, and these ones will be as a parameter for us in case there's a change in the heart size, or we can see effusion. So these can create a parameter. We can skip to the next one. So in this one, I'm focusing on like important findings, and one of the important findings are the cardiac. We can see here enlargement of the heart, and how we can know that. We know it by the cardiothoracic ratio. We calculate the a maximum diameter of the cardiac silhouette to the maximum diameter of the thorax. In interior posterior position, it shouldn't be more than 0.6, and in posterior interior projection, it shouldn't pass 0.5. So in case these parameters are higher, it's a sign of enlargement of the heart. Okay, go. Another two features of the heart that these ones very important in case they want to let you pass, they will ask you these questions. The mitral valve, how mitral valve disorders and aortic valve disorders appear. We will see that the left atrium is dilated and plugging of the left atrial. There's like, if you see where's the arrows, it's gonna show us it's like a more white and like a bit rounded. So it's the central shadow, and we can see the double right counter. If we look, it's gonna look like a triangle, like the heart of the heart shape look like a triangle. And this is due to mitral valve disorders. On the other side, we have the aortic valve. We can see that the left ventricle is dilated. Like it's more, you can see like the costophrenic sulci is reduced as it was before, the size of it. And we can see it's sinking more to the apex, like below the diaphragm. And we also have here central shadow and the double right counter. And if you look from above, until it looked like a duck shape. So if the heart looked like a duck shape, it's a sign of aortic valve disorder. Some features that show also pathological features like pneumonia. So as we said, the lung is supposed to look black because we have air in the lung. So in these pictures, we see that the lung is becoming more whitish. So we can see here in the left that we have here white, so it's can be pneumonia. In the second picture, it's more whiter, so it's pleural effusion. And the last one, very, very important thing, you see how the pleural effusion is like almost the whole lung is filled with effusion. So the esophagus and larynx, like the mediastinal, are shifted to the normal side. This is very, like, when they ask you which side is shifted, the mediastinum, when we have edema on the right side, it must be shifted to the normal side. So it's shifted to the left. This is also one of stuff they focus on. We can skip to the next one. In this one, we can see like a hyperinflation of the lungs due to pneumothorax. So usually the heart, if you see in the left picture, there's like a green lines. This is the normal position of the heart. So in pneumothorax, we see that the heart is shifted more to the right, and there's like a increase of the costophrenic size. Okay. In the lower picture, we can see aspiration of a foreign body, and we can see an ileus. You see the enlargement of the GIT. We have bone fractures, which is the most easiest one to recognize. And then we have like the tumors, osteosarcoma, where the bone density is increased. We have bubbly bone lesions, and we can see here a tumor, osteochondroma, in the lungs. If you see this is the lungs, and you can see this mass. So it's going out of the bone, so it's osteochondroma. Principles of CT. Do you have any question for X-ray before I move on to CT, or everything all right? Okay, so I'll move on with CT. So CT is mainly based on X-ray method, but in the difference between X-ray and CT, that we have two types. We have conventional and spiral. Conventional, like it's a stationary, and we have 1 to 1,000 detectors, and it's placed, the X-ray is a round machine, and these detectors are placed in different positions, and they will send the X-ray beam through the patient. And then the second one, the spiral one. The spiral one is a continuous rotation, 360 degrees with one detector, or we have a multi-detectors in row. So these detectors will run through the patient when he's lying in supine position. So how is the picture is created? So CT, as I said, I explained like how the beam and all the physical things that occur in X-ray, it's the same in CT, but the one different is how the picture is reconstructed. So CT is also based on density. So it's the density of tissue passed by the X-ray is measured by calculation of attenuation, so the absorbed and the deflected energy. So the picture will be reconstructed in 2D picture matrix element, and each pixel have a different grayscale depending on the absorption of tissue. So, and each pixel have a unique shade of gray. So if we have high absorption, so we'll have a higher shade of gray. us as a human, we only see 16 shade of gray, but like there is like a more and thousands of shades. We express it as a Hounsfield unit. So if the Hounsfield unit is brighter, is higher, so the brighter it will appear on CT image. The next picture, I will show the scale. Can we pass it? And this scale is very, very important, and they want you to draw it in the final. So the 0 point is the water. So if it's lower than 0, so it's hypodense, it's darker. And within it more than 0, it's hyperdense, and it will be white, or we call it shadow. Then we have two windows, width window and lever window, and these windows will allow us to adjust the contrast on a different level of Hounsfield, as which like gray scale we want to see, but we only can see 16. But this will help us to be more specific. So we can see a wide window. Wide window, we can see all structure, but it's very bad details. And there's a narrow window where we can see small details only, but with a tissue with the same density. So like, for example, if they would like to ask you, I want to see a soft tissue window, or like a bone window, we can skip to that one, to the next one. So like, for example, if he wants to see like the lung window, so it has to be like between 500 minus 500. If he wanna see the bone window, so it's gonna be plus 500. So we can make it more specific by going to specific Hounsfield, a gray Hounsfield of a gray shadow. So just remember that lung, mediastinal, and bone window, these ones to mention in the final. These some examples for how CT appear on the imaging. So we can see the fractures of the skull. I don't know if you can see it, where the red one, and we can see epidural hematoma. The second one, we can see brain metastasis. So these are blue and green one. There's also a feature, I didn't add it, but like one of the brain tumor, schwannoma, and it will appear as a ice cream cone. This one also like easy to recognize. Can we skip the next one? Here are normal findings of a CT abdomen, where we can see the inferior vena cava, the blue one. On both sides, we can see the kidney. This is more to the right, more to the left of the teams. We can see the liver. Sorry. I'm sorry, we can continue. For the, we can see the colon. We can see, yeah, the duodenum. This is like a beige color. On the other picture, the black one, we can see cholelithiasis. You can see like stone within the gallbladder. So this is the liver, and this is the stone within the gallbladder. Can go. We can see pulmonary embolism. So these blue dots show as a embolized pulmonary vessels, and we can see the red one, which is spondylolysis and dislocation of the cervix, as it shows between C6 and C7, this point, the red point. Do you have any question about X-ray and CT? Okay, then we can continue with ultrasound. Tarteel?
Yes, 1 second. Okay, so we can start principles of ultrasound. I think this is the easiest, so yeah, don't worry about this one. Okay, so ultrasound, it's the I don't know how to pronounce it correctly, but piezoelectric effect of ultrasound. So the transducer of ultrasound usually has crystals that emits ultrasound waves, and these ultrasound waves will either be reflected, absorbed, whatever it is to the organ, and the ultrasound wave, when they are reflected, they usually cause the crystals to vibrate and produces some sort of electrical energy that is then translated to like a picture on the screen. So this is the principle of ultrasound, like simply. There are usually low frequency probes and high frequency probes. The low frequency probes have good penetration but poor resolution, and the high frequency probes have good resolution but poor penetration. I think this is important because um, do you know the frequencies that ultrasound transducers like usually operate on? Normal frequencies that you guys know? It's okay. It's like 20K hertz till 500 megahertz usually. These are the frequencies that the ultrasound operates on. And yeah, this is basically how the ultrasound generates the image. So on ultrasound, you can have like the structures can appear differently. The anechogenic, hypoechogenic, and hyperechogenic. The anechogenic meaning that there's no sound wave that is being reflected, and this is usually so it appears like black color on the ultrasound, as you see here. These are usually like any fluid-filled cavities, the gallbladder, and also urinary bladder, the vessels, because they contain like fluid, and this any cysts. Hypoechogenic, it's more, there's no low reflection, as you can also see on the screen, and usually it's like tumors or lymph nodes. And hyperechogenic, there's like there are strong, these are strong reflectors of like the sound waves, and so they appear lighter in color, as you see here as well. And usually they are fat tissues, lipomas, and stones. Isoechoic, you don't have to like know it, but it's just that it looks like normal-ish on the ultrasound. So it just has a gray color, and it means like it's same reflection as in like the surrounding. Okay, so there are two phenomena I think you should know in ultrasound. There's the acoustic shadow and acoustic enhancement. In acoustic shadow, this means that there's a hyperechogenic structure. So we talked about them like lipomas, fat or like any calcifications. All the sound waves are reflected usually from that stone, and any structure behind it will appear black. So it's just a shadow behind a stone or a calcification. If it is acoustic enhancement, it's usually anechogenic structures. So we talked about them like cyst vessels, the bladder, any fluid filled structures. All the sound waves are usually transmitted through, and the structures behind it, they usually absorb the sound, like the energy, and disperse it, making it appear enhanced. So acoustic enhancement. Sometimes they call it like posterior acoustic shadow and posterior acoustic enhancement, but you can just know them as acoustic enhancement and acoustic shadow. Okay, advantages and disadvantages. The advantages that it's portable, it's easy to use, like good for soft tissue, and it's relatively cheap. The disadvantages, it's usually not suitable for lungs and the bowels because of the air. Also, it's not suitable most of the time for any fat structures, obese people, or like bones as well. And the resolution is not as good, and also depends on the person operating the ultrasound because it requires a lot of training. Do you know, w- like, if we can use, when can we use ultrasound, for example, to look at the brain? Is it possible to look at the brain using ultrasound? Do you guys have any clue when that could happen? In newborns, yeah. And do you know why? Yeah, through the fontanelle, exactly. Um, yeah, could also be. And for example, if someone removed a part of their skull, for example, to treat like intracranial hypertension, you can also use ultrasound. But usually it's like for newborns and the fontanelles because the bones are not ossified yet. Yeah, also some disadvantage of ultrasound that he mentioned that was so random and it's very rare, does not even happen. It's cavitations. It can cause cavitations. I don't think you need to know them, but I remember he just mentioned it once during the seminar. Okay, so you know you have the superficial ultrasound, the one that you use the gel for, the to like to reduce the air, like the air interface, and then you have like the endoscopic one. And then we have the Doppler ultrasound. The Doppler ultrasound basically measures the blood flow by reflected waves from the red blood cells. And the shift, like the frequency shift, is usually according to the velocity of the blood. So basically, it just measures, not measures, but like shows you the blood flow. We have two types of Doppler, the color coded one and the spectral. The spectral one shows us like velocity, and we use Doppler ultrasound, for example, to confirm occlusions of vessels by thrombus. Usually, if the vessel is obstructed by a thrombus, you're not able to compress it. So this can be used to check for like deep vein thrombosis. If you place the ultrasound transducer on the vessel and you try to compress it, usually veins are compressible. But if it doesn't compress, then you have to suspect that there could be a thrombosis or like deep vein thrombosis, and also can be used to check for like increased blood flow in tumors and inflammations. You cannot confirm stenosis with color coded Doppler. You have to use spectral to see the change in the velocity, but color coded can only give you like a suggestion of stenosis. And usually the picture in color coded will appear like this. You see a red part and a blue part. The red part just means that the flow is towards the probe, and the blue part it's away from the probe. That's basically it for ultrasound. And I'll show you a few pictures if you can try to tell me what you think that is. So, can you, if you want to open your mic and describe the picture, you can. And like, don't tell me the diagnosis. I just want to know, like, what can you see? Or you can type it. Doesn't matter. Okay, yeah, go ahead.
It looks like an ultrasound in the B mode, and I
Uh-huh.
think that's the gallbladder that's being visualized.
Mm-hmm.
So there seems to be a hyperechoic area with a posterior acoustic shadow, so
Mm-hmm.
it might be a gallstone.
Exactly. This is how you should describe it also during the final. Amazing job. And then another picture. And yeah, you can tell it's the gallbladder because if you check on the side, can see the liver and it's like the possibly the what is it? The duct system in the liver. And what is this? And I think it's hard to tell what kind of abnormality is this, but like you can describe the ultrasound. Does anyone want to go? You can also type it. It's fine. It's okay. Don't be nervous. Just like the simplest things that we just said right now. Okay, I'll do this one if you guys want, and then the next one you can try. So this is ultrasound, Doppler ultrasound, color coded ultrasound in B mode as well, and you can see that there's like a structure like an echogenic or hypoechogenic structure that has some blood flow possibly, and yeah, you can just see that there's like some turbulent blood flow going on, and it's actually seminoma. So it's just for a tumor, highly vascularized tumor. So yeah, you can use Doppler ultrasound for it. Do you guys know how to differentiate between torsion and epididymitis, like the inflammation? Exactly, exactly. Uh, exactly. Presence of blood flow or like decreased or reduced blood flow. Usually in torsion, you might not even see blood flow, but in epididymitis, there's like increased blood flow because it's an inflammation in that. And the last one should be easy, a bit easy. If anyone can just guess, you don't have to even describe it. You can guess the diagnosis. It's fine. Because okay, we know ultrasound, Doppler, and but we can see something on the ultrasound. Uh, Stenosis could be, but stenosis is like you see like turbulent blood flow usually. So you see like a mixture of colors. But here, like look at the red structure. Also, it's difficult to say which vessels these are. So I'll give you a clue. These are the femoral vessels. Hmm? Oh yeah. Yeah. You don't have like during the final, you don't have to say which vessels you're looking at. You can say vessels, just a pair of vessels. But if you look at the red structure here, you can see that it's not completely circular. There's some filling defect. So it's probably a thrombus, like a thrombosis of the vessel, which you don't have to name. Like it's like a wild guess to say femoral. But if you look to the surrounding structure, you might be able to see like the hip bone and whatnot. So You can deduce that it's the femoral vessels, but you don't have to. And yeah, it's just a filling defect, indicating that there could be thrombus. And if it's in the femoral vein, if you try to compress it, it will not be compressible. So that's it for ultrasound. Do you guys have any questions about ultrasound? I know for ultrasound, there's also the A mode, the M mode, and B mode, but we rarely use them. I think you just need to know them in theory. We mainly use the B mode. So, any questions for ultrasound? No? Okay. So, thank you guys. And now Malaz will discuss MRI with you guys. Okay. So, for the principles of MRI, we just go quickly on how MRI works. It's a non-invasive technique. So, the MRI, the most important the most important thing is the presence of water molecules in the body, because for it to work, normally your body is made up of water, also your tissues, and the water has hydrogen atoms. These hydrogen atoms, they are naturally in a spin. The protons in the hydrogen atoms, they are spinning, so they create some kind of magnetic field. And when an external magnetic field, a strong external magnetic field, for example, coming from the MRI machine, it causes the protons to align with the magnetic field of the MRI. And then the MRI produces some radio frequency pulses. These radio frequency pulses, they change the alignment. They displace the proton from the hydrogen, and they change the alignment either to 90 degrees or 180 degrees. And then once the radio frequency pulse is removed, the proton should relax and go back to its original state. And when it does that, they release some kind of electromagnetic waves that is detected. And depending on how quickly the proton relaxes, it can create the image, the different kinds of modalities of MRI. So how quickly the protons realign with the magnetic field after the pulse is removed, this is for a T1 image. And how quickly it loses its coherence after the pulse has stopped, this is for T2 image. There are other modalities that we will briefly discuss, but this is the main principle for it. The most important thing about MRI that it is not invasive, and there is no ionizing radiation that is produced. No ionizing radiation. So you can use it for contraindications of CT and X-ray. If there are contraindications, especially in pregnant women or people with like young people that you don't want them to expose to that dose of radiation. And the thing with MRI is that it's not always a first choice. It's mostly never a first choice because it's um, it's time consuming. You need at least 30 minutes to produce an image. It is expensive, and it's not very comfortable to the patient staying in the machine for a long time. But it could be used, especially in like it's most importantly in the brain tissue, but it could be also used sometimes in other like organ system, even though X-ray, ultrasound, and CT would do much better, but sometimes the image or the results are inconclusive. So you need better imaging techniques, and that's from MRI. So as we said, MRI, it's mostly for the soft tissues in your body or in the brain. Not really for the lungs because they have a lot of air, and the most important thing we need is water in order to see something, visualize something from the MRI. So not for the lungs, but we can see something in the mediastinum or the chest wall, some tumors that we will go to later on, and in the bones, not really the bones, but the bone marrow, because it contains some water or some like the cartilage, the menisci, or the ligaments. So important for tumor evaluation and sometimes staging. And also the most important use for it is in the CNS, whether it is like a tumor or an inflammation or infection, neurodegenerative diseases, for the spine, all of these, you can see something on MRI. Contraindications are any object, any ferromagnetic object,
So it could be like clips that are used for aneurysm, some pacemakers, some stents, because the problem with these is that they will interfere with the magnetic field and can either alter, you can produce artifacts, and it can also harm the patient themselves because it can lead to the risk of like heating of the object, and also if it's a pacemaker, it can lead to malignant arrhythmias. So the MRI modalities. There are several. The most important you need for you is T1 and T2, because also your images, the images that you have for the final exam, they are either T1 or T2. So you need to distinguish between both sequences. There are other ones that are important for neuroradiology. I think you did not have the neuroradiology seminar, but there are other modalities that you need them because they can distinguish some like specific diagnosis. So for T1, we said it's how quickly the proton realigns after the pulse has removed. And if you want to describe an image or MRI, you need to use hyperintensities or hypointensities. In a T1 image, hyperintense is anything that it's like fat or adipose tissue or even contrast media. Hypointense, water. Water, anything that has water would look darker on a T1 sequence. The opposite for T2, hyperintense would be water, and hypointense would be like adipose tissue or even fat. This is, if you want to remember it, WW2, World War II, water is white in T2. This was from AMBUS, so you can keep it in mind to remember it. Yeah, there's another sequence which is called the flare. I think you will hear about it in the neuroradiology seminar, which is fluid attenuated inversion recovery. It suppresses any signal that is coming from water in general, free fluids. So you can see better, like you can see like fluid-rich areas. Like for example, in the brain, in the ventricles, you can see, you don't want to see the CSF, but you can see structures, other structures that are in the CSF. For example, it could be like a cyst, or it can be calcifications. So you can use this in multiple sclerosis, in brain inflammations or infections like encephalitis or meningitis. So this is how the three of them would look differently. A T1 image, so you can see mainly the brain tissue, which is as a hyperintense. In T2, you can see the, what is it called? The water as hyperintense. In flare, everything, somehow everything is attenuated. You can't see anything, not water, not like the tissues, but anything else around in the, for example, in the ventricular system, anything that is a region that is filled with water, you can see, you will see something inside it. There's also diffusion weighted image. So this diffusion weighted image, it relies on the random movement of water. So it tells you about the diffusion of water through the tissue, if there is any restriction. So if there is a restriction, then you can, which is usually due to ischemia or ischemic stroke, or sometimes abscesses or tumors that are restricting the water diffusion. So these will be highlighted in diffusion weighted images. There is the ADC, which is the apparent diffusion coefficient. It's a coefficient that measures the diffusion of water molecules, and this relies on that imaging technique, the diffusion weighted image. So the higher the value, the more likely, this means that there is less restriction, and this is normal for a healthy brain tissue. But the lower the value, the more the restriction it is, and it's like either an infarction, ischemic stroke, or an abscess, something that is restricting the blood flow. You can, yeah, it's easier to use this compared to the CT, because sometimes this can work faster than a CT if you're trying to like any restricted diffusion. There is this susceptibility weighted imaging. It is highly sensitive to the differences in the magnetic susceptibility of the tissue. So you can distinguish between either some blood products or calcium deposits. It's mainly used for, like in the neuroradiology lecture, you will find that it's mainly used, it's high sensitive to diffuse axonal injuries. It can also be for neurodegenerative diseases, or cerebral venous thrombosis. Now, for all these sequences, you can mention them in your oral exam, but the most important two that you really need to distinguish and you really need to tell the difference between are T1 and T2 weighted sequences. So this is an image for all the different sequences. There are other more sequences, but like these are the most important. So you have a native MRI without contrast, and you have an MRI with contrast. And the contrast medium that we use in MRI is gadolinium. Gadolinium, it has like paramagnetic properties, so we mainly use it and only for T1 weighted images because it enhances the image there. It makes it brighter by shortening the T1 relaxation time. You apply it intravenously, and like any contrast media, the problems with is like how it is excreted from the body. So a person, usually it is excreted through urinary system, through urine. So a person with reduced kidney functions, it could be problems. And there are some, it could be neurotoxic as well. Yep. So this was an image. The one to the left was an image without the contrast media. So you couldn't really see the lesion. And after the contrast media, there is like, it became more hyper intense and you can see the mass. So the use of MRI, because I said MRI is not always a first choice, but we can still use it as a part in different for different organ systems. In cardiology, in cardioradiology, it gives you important information about the anatomy of the heart. You can measure the size of the heart chambers, the thickness of the wall, and you can assess the function of the heart. You can differentiate between arrhythmias. You can easily see the different types of cardiomyopathies, all of the cardiomyopathies, and also for congenital heart diseases, and also evaluate the valves and any defects with the valves. Now, because in MRI, sometimes the patient would move, and this would produce artifacts, but in order to make the image, to have a better quality of an image, they usually synchronize it with the ECG. And this is also for CT. But yeah, it's important so that you have a better quality of the image. And as we mentioned before, for contraindications that pacemakers, and there is a risk of malignant arrhythmias with pacemakers. For pneumoradiology, we don't really see the lungs with MRI because it's full of air, but we can see tumors in the mediastinum and the chest wall, especially Pancoast tumors. So for evaluating Pancoast tumors that are tumors at the apex of the lungs, you can use MRI. Abdominal radiology. We use MRI a lot here as well. You don't really have picked images on like for the practical part for MRI enterography and MRI enteroclysis, but it's good if you would mention them when you have, for example, imaging of the abdomen or questions of like the intestines. So MRI enterography, it's a procedure that uses oral contrast material. So the patient is ingesting the contrast. But in MRI enteroclysis, the contrast is directly going into the small bowel through the nasogastric tube. So if you're trying to distinguish between them, enterography is less invasive than the enteroclysis. Enterography is mainly for if you're evaluating active inflammation or neoplasia, Crohn's disease, fistulas, strictures, or inflammations. Enteroclysis is for this, it's similar, but it's more likely to, it has higher sensitivity to the tumors, to the strictures, to the inflammations. But it's just more invasive, and it is more like you're causing more discomfort to the patient. MRCP, magnetic resonance cholangiopancreatography. You have an image for this in the pictures, and it's important to know that it's for evaluating or interpreting some findings in the liver, the biliary tract, and in the pancreas. You can evaluate some conditions like the gallstones, tumors, strictures, inflammations, or congenital abnormalities. It's an alternative, a safer one to ERCP because, with ERCP we have complications. And what kind of complications can you, could arise from ERCP? Yeah, it could be uncomfortable, exactly. Like what other complications ERCP? Because there are major differences. The problem, MRCP is much more safer. ERCP, yeah, go ahead. Yes, exactly. It can cause acute pancreatitis. Exactly. This is, yeah, the Terti was saying the mnemonic I get smashed. The E is ERCP. So yes, exactly. ERCP causes acute pancreatitis. It can cause other complications like leaking. It can cause infections, but acute pancreatitis, yes, exactly. And the difference also between MRCP and ERCP is that MRCP is only diagnostic, but ERCP is both therapeutic and diagnostic. Exactly. Keep that in mind because it's important, because I had the questions of imaging of the biliary tract, and when going through each one of them, each method of diagnosis, from where I will start. For example, if it's a stone, I can, if a patient comes with abdominal pain, I can do an x-ray. If it doesn't work, I can start with an ultrasound, and then later on, if I see if it's stone in the biliary tract or the gallbladder, I can indicate it for ERCP or MRCP, it depends. That's how we go about in the exam. So for example, let's see, can you guys try and describe this image for me? What do you see? What is this? Where are we? You can write it, you can open the mic, don't worry. Yes, exactly. Bile duct, yes, exactly. The bile duct is dilated. Yep, exactly. I don't know if you can see in the bile, in the duct, there's like a stone. Can you see it? Like some contrast like this, like a stone? Yeah, exactly. So this is um an MRCP of the biliary tract. Exactly. There is a stone, there is dilation of the duct, the extrahepatic is dilated, and also the intrahepatic bile ducts are dilated. Exactly. That's enough for this image. Okay, in neuroradiology, uh, it's for evaluating especially tumors of the pelvis, the kidneys, the bladder, prostate, adrenal glands, and also the surrounding structure. You can perform, it can be just a static examination, or it can be a dynamic examination where you are administering gadolinium, and it's like you're seeing how the contrast is moving through the system over time to assist like the tissues and to assist like perfusion and vascularity. So you have a special tumor, angiomyolipoma, which is a tumor that has high fat content. I think maybe you remember it from pathology. So this tumor, it's it's sometimes problematic to see it on CT and ultrasound. And in MRI, there is some phase, because it was mentioned in your lecture, the opposed phase MRI. It's a specific MRI technique that you are finding the differences in the tissue composition within like the different composition. If it is like muscle, if there is high water content, if it's vascular, it has vessels, or it has like fat content. So you can distinguish between these, and it's mainly used for that angiomyolipoma. Fusion biopsy, it was not mentioned in your lectures, but I think maybe it's interesting to know. In the urology department, they were using a technique where they are combining ultrasound and MRI to take for the diagnosis of prostate cancer. So they were taking samples, the biopsies. They were using both. They were using the ultrasound and the MRI so that they can like it's like for better visualization of the mass, and they can easily take it without having to repeat like multiple biopsies. So that was interesting to see the fusion biopsy. For the reproductive system, especially in gynecology, also evaluating of tumors, ovarian tumors, endometriosis, cervical tumors, and pelvic tumors. And it can also sometimes used for prenatal diagnosis, uh, to assist the fetal development, to detect any structural abnormalities when sometimes the findings on ultrasound, because it's better to use ultrasound, it's much easier and faster to use ultrasound for assessing like the structural abnormalities throughout the pregnancy. But sometimes if the results are inconclusive, they can use MRI. So for example, here you can see like the fetus growing. Can you tell me which MRI, like which modality, which sequence this is? Do you think this is T1 or T2? Okay, so and this is a T2, because you know the fetus is in the amniotic sac, and the amniotic fluid is in water, like composed of is a fluid composed of water, so it's a bit brighter than the surrounding tissue. So we said World War II, water is white in T2. So this is a T2. Okay. This is also an image from your from your images from the practical. And so this is like the uterus, right? And this is the fetus. What is this? What is this hyper intense structure that is under the fetus? It's again hyper intense. What could it be? Okay, guys, guess something. Okay. This is the urinary bladder, which is filled with urine. For osteology, we said we can't really see the bone, but we can evaluate the bone marrow. We can see the soft tissues, the muscles, the ligaments, the menisci, the cartilage, yeah, and the bone marrow. So it's like it tells us about the extensiveness and the viability of the tissues. There are arthropathies that or arthritis, where you can use MRI for it, and you can see like the accumulation of intra-articular fluid, or there is like hyperemia, thickening of the synovial lining. And I also think you didn't take this. Maybe they will explain it, like you will have a better explanation at the seminars. But there's also the MRI arthrography. I don't think you really need to know it in details, but just because it was mentioned in your lectures, it's like an imaging technique that is used to evaluate the internal structure of the joints, the ligaments, the cartilages, and the soft tissue. This is done by injecting contrast agents so that you can evaluate um, different conditions. Also for congenital hip dysplasia, this can be used. Neuroradiology, this is the most important, like really used for MRI. You can start with a CT, and if CT findings were inconclusive, you can um, do an MRI. So you can evaluate the brain, the spinal cord, the peripheral nerves. You can detect so many different conditions. You can evaluate hemorrhagic and non-hemorrhagic and ischemic strokes, multiple sclerosis, epilepsies of if it was caused by structural abnormalities, neurodegenerative diseases, infections or inflammations of the spine, especially at the early stages, arteriovenous malformations, diffuse axonal injuries, we said for the susceptibility weighted imaging, and also metastatic lesions. So a lot of them, and sometimes there are specific findings for each diagnosis. It's actually well written in the neuroradiology lecture. I think that neuroradiology lecture, it was long, but they had like everything there for herpetic encephalitis, for multiple sclerosis, what to expect. Even when Lina mentioned the ice cream cone for schwannoma, it's there written because it's important finding actually. There is the swirl signs for the epidural hematomas. There is Dawson's fingers for multiple sclerosis. Everything is written. I think that neuroradiology lecture is really nice. There is MRI perfusion and MRI spectroscopy. They also mentioned it. For MRI spectroscopy, you're just measuring the different chemical compositions and the metabolism of the tissue. So they're measuring some chemical contents, like some chemicals like choline, lactate, glutamate, and to evaluate some conditions. But you don't really need to know it. Maybe you should know about the MRI perfusion, which is for perfusion, just like CT perfusion, to measure the blood flow in the brain, to evaluate the vascularity of the tissue. So if you can tell about any tumorous growth, because it would be highly vascularized, any brain damage, places of ischemia. There are parameters. I think it was mentioned in the lecture, the cerebral blood flow, which is indicating how much blood is passing through the brain tissue per unit of time. The cerebral blood volume, the mean transit time, which is the average time taken for the contrast to passes through like the region that you are studying, and time to peak, which is the time taken for the contrast to reach its peak concentration in the tissue. So any delay in the mean transient time, this means that the area is there is poor circulation, there is decrease in the blood flow to that region. And if the time to peak is prolonged, this means that there is some abnormal perfusion in that region. We can also use MRI for evaluation of the breast. A native or non-contrast MRI, you can evaluate any breast implant rupture, but a contrast MRI, you can use it to screen patients, high-risk patients, for example, with the BRCA mutations, to stage breast cancer, to monitor the effectiveness of the treatment, and you can use it to detect cancer because for breast cancers, ultrasound and mammography are the most important, not really MRI. But in case the results from there were inconclusive and you actually have pathological findings from the lymph nodes, axillary lymph nodes, then you can indicate the person for an MRI. And lastly, we have for interventional radiology, MRA, magnetic resonance angiography, just like the CT angio for visualizing the blood vessels and the blood flow. To detect any vascular abnormalities, any blockage, any aneurysm, you can use it with or without contrast. If it's without contrast, then this is the MRA, time of flight, which is the time taken for the blood to travel through the magnetic field. And when the blood flows through the magnetic field, this means that it will be exposed to radio frequency and also the protons in the blood. When it is exposed to the radio frequency pulses, the same concept, instead of water, it's for the blood. So you are visualizing the blood vessel itself without the need for the contrast. And this is really, especially in the brain tissue. You can also evaluate lymphatic diseases. You don't really, of course, you have ultrasound, but you can also use like MRI. So this is a normal MRI. To the left, T1, no, T2, because water is white in T2. You can see the hyperintensity in the ventricular system. And so if you're looking at this image and you're trying to think if it's CT or MRI, because sometimes I confuse. In MRI, you don't really see the bone, so you can't really see the bone, the skull. And usually in the MRI, it depends if it's T1 or T2. There should be something that is hyper intense. Usually, if you see the ventricular system, it's more likely to be an MRI, a T2 scan, because it's like there is brightness of the water. And to the right, this is the MRI angio, when you can see the vascular system. So, can you please describe this image for me? So now we just have like few images, and these are random images also from your questions, like from the pictures that you have. So, and I promise you we're going to end. We're almost ending. So can you guys try to describe this image? Like, tell me which modality of MRI. This is so everything now from now on it will be MRI. Which modality, which organ system, and what do you expect? You don't really have to tell me exact diagnosis, but what do you expect? So this is MRI. True. Which organ system this is? Or what can you see? Which like organ or structure can you see? Uterine fibroids. You're right that this is the uterus, this is the reproductive system. Uterine fibroids, I think they could be a bit more inside the uterus, but this is not a bad guess. This is a great guess. It could be. Actually, this is more of like, you can see like a lesion at the beginning of not the uterus, at the cervix, actually. This is in the cervix. And there's like a mass, a hypo intense mass, and more like edema. So this is a T2 sequence of MRI. this is we are at the uterus and the cervix. There is like a hypointense mass at the cervix, more of like edema, or so this could be a tumor. This is actually cervical carcinoma of the cervix. But you don't really need to say that, but you can say like it's a tumor. Okay? Is it clear? I know MRIs are sometimes a bit difficult compared to the rest. So how about this one? This is a bit easier. Yes, okay, thank you. This is easier. Again, this is MR, but something. Go ahead, guys. Don't worry about it. Actually, no problems. I know you still didn't uh really go through all of these, but like just tell me, like, since we are now seeing vessels, that should be like what? Since which part of the body this is. You don't really have to tell me diagnosis. Don't worry. Diagnosis, we'll let it for later. So since we're seeing the vessels, so this is an MRI angio, MR angio. This is at the level of like we can see the kidneys, you can see the renal arteries, we can see the aorta, the abdominal aorta, but the flow of blood is not, we cannot see the common iliac arteries. We can't see the common iliac artery, we can't see yeah, we can't see them. So there is like an obstruction of the abdominal aorta at the level of like near the level of the kidneys. Can you see it? So this is like, and it is a total occlusion, not even partial. So there is no blood, there no contrast, no blood, no contrast is flowing. It is stopping at the level of the at the level of the kidneys. We can't see the common iliac arteries. We can't see any arteries from below. You can also see, you can see this is like, I can't see the celiac trunk, but you can see the superior mesenteric artery going down. Okay? Okay, so maybe we can go to another image. Maybe this is this. So tell me, there are two images. So tell me like both of them. Again, you don't have to tell me like the diagnosis exactly, but what do you think? This is, we still have two more images, guys. Don't worry. I know that it took so long, but like just have two more images. So let's start with the image at the left. What do you think, guys? Which imaging technique? What can you see? Yeah, exactly. And so the image at the left, because you said the right term, it's like a hypointense. Oh wait, not the. Sorry, it is hypointense. It's like edema, exactly. But um, the images, the imaging technique in the image in the left and the right, they're different. So in the, yeah, Exactly, exactly. On the left, this is a CT. So it's a hypodense lesion. You're right. There is definitely edema of the brain tissue because we can't even see the ventricles. Did you guys notice the ventricles are not there? The ventricles are not there. So there is definitely an edema. And it's a CT because you can see the bone. The bone is really visible in this image. Unlike the other one, you can't really see the bone, and it's an MRI. You can see the difference of the same lesion, but you can see how how it's visualized differently with different techniques. Now, since there is edema, I think you remember, yeah, from pathophysio, you have different types of edema. You have the most important two that you need to know for this exam is vasogenic and cytotoxic edema. Where can you find them? Where is vasogenic and where is cytotoxic? In which conditions? Okay. Yep, exactly. In cytotoxic, exactly. In cytotoxic, you can find it in ischemia, and vasogenic is in tumors and abscess. Um, you can't really tell which kind of edema in the imaging technique, but if they ever ask you, you should know them. At least these two, you should distinguish between them. So this image, you are right. It's okay. To the in the left, this we said it's a CT. There is a hypodense lesion. It's more of like there is also edema. We don't see the ventricles. Um, is this a native CT or with contrast? Because this is important also to say if it's native or in with contrast. Okay, it is a native city because we can't really see the vessels. So it's a native city, hypodense lesion, there is edema, we cannot see the ventricles. The image to the right, it's an MRI. It's there is a like a somehow a hyper intense lesion. It's more hyper intense compared to the surrounding. You can say that even if it's not really hyper intense to you, but you can say compared to the surrounding, compared to the rest of the brain tissue, it is more hyper intense. It looks somehow uniform. It looks like diffuse throughout the lesion. You can say that you can actually describe what you see with correct terms and what you see. And it's like a T2 weighted sequence. So this is a tumor. You can see it is edematous. You can see comparing like the left side of the brain on the MRI image, the left side and the right side, you can see that the left side is more edematous. It's you can say it's a tumor. That's enough. If you're able to tell exactly what it is because of the location, it's like an intraaxial tumor. You can say this is like diffuse astrocytoma. But you will still learn this, inshallah, like next week in Radiology Seminar. Okay, so we have this one and the last one, I promise. I know it. We're almost done. So go ahead, guys. What do you think? Yes? I I can't hear you if you're trying to speak, actually. I can't hear you. So guys, what do you think this is? Yeah, okay, okay, exactly. The first is CT. That's very right. Yeah, the first one is a CT because you can see clearly the bones. You can't really see the soft tissue, but you can see the bones. It's a CT. And the other two are MRIs, but different modalities. So which one, the first one of the MRI, which modality it is, and the second one? Exactly, exactly. The first one is T1 and the second one is T2. Because in the first one it's T1 because you know the intervertebral discs. The intervertebral discs should contain some water actually, but you can't really see them. You can see them better in the second one, in the second image. So that's, and you can also see the CSF through the spinal canal in the third image to the right. So this is the spinal cord. There are different images, CT, MRI T1, MRI T2. There is a fracture of the spinal cord. It's unstable fracture, and I think that's all. That's all that what you have to say about this. Last one, the last image. Again, these are two different modalities, two different techniques. Exactly, exactly. CT, and this is MRI T2. Exactly. Now, what's the main issue? What's here? What's happening in these two images? Exactly. Actually, both are hydrocephalus. It's like for the same thing. It looks different I know the same diagnosis would look different. It looks different a bit in different techniques, but both of them are like hydrocephalus. There is dilation of the ventricles. Exactly. And there is an important thing that you need to know in both CT and MRI. This is an active hydrocephalus because see the edema surrounding the ventricles, the lateral ventricles. There is like some edema around the ventricles on the side. It looks like either hypodense in the CT or like hyperintense in the MRI. This is this indicates that hydrocephalus is active. It's still active. And there is something that on the CT in the ventricles, you can see like a white, very hyper intense lesion. Very hyper intense, very hyper dense. What do you think this is inside the ventricles? It's very hyper intense. Like according to the Hounsfield units, what could be it's so bright. It's so bright. Okay, these are it could be, but these are calcifications. It's calcifications actually that occur. These are normals. They occur in the ventricles. In the choroid plexus, you can find them as well. But sometimes, if it occurs somewhere else, it could be an indication for meningiomas because there are a lot of calcifications in meningiomas. So, yep, this is the end. Do you guys have any questions for MRI or like any other modality? Technique, imaging technique? Do you have guys any general questions? So, because we did not record the first part about the exam, you guys are free to ask in the chat, or like you can ask, like you can open your mics and ask. So, for the exam, uh, you have for nuclear medicine, you really don't need anything extra. The technical questions, you have the answers for them. For the like the clinical questions, these you also have the lectures, and the lectures are more than enough. I think if you know them and you say like everything there in the lectures, that's enough, and they're really nice. For radiology, because you will in this exam, before doing the oral part of nuclear medicine and radiology, we'll start with the credit test. As Lina and Tarteel mentioned to you, yes, they are. Melina's notes are good. I think these are the most organized notes. There are also some notes. I think they are on the Dropbox. It's like notes of what the doctor said during. It's like written, not handwritten, but like they're typed notes of what the doctors mentioned during the exam. So you can really go through these, and these are like exactly like what they said during the not the exam during the lecture. So you can
Seminar.
yeah, lectures and seminars. So it's you can also go through them. Melena's notes is nice in terms of
It has everything. Like she mentions everything in that note, so you can use it. Even like I think she goes too deep into the topic as explaining its pathology and pathophysiology, which sometimes you don't need. Like if you know what the disease is, like you can explain it and just say the radiological findings. But I think for like the rounding up of knowledge, she uses as well the uh, the what is it called? Uh, Pathology and pathophysiology. So you can use these notes um, as well as the seminars. Use the seminars to study. For the credit test, which you do on the day of the examination, I suggest you solve the tests on Moodle, as well as like share your tests with each other to figure out, okay, this might be wrong, this might be correct, and do the final, like the past papers. And I think it will be fine, but try to like go through the questions. There'll probably be a lot of new questions as well. There's especially nuclear medicine questions, but if you study the lectures, they'll be fine. The credit test will be fine. For the final, the pictures, like you described them as we said, you start with the what modality of imaging is it, and then like describing it like hyper intense, hypo intense, or like density or the echogenicity.
the right term for it.
Yeah. And what it possibly could do, but don't blurt out the diagnosis at the beginning because they're like, okay, we get like you know the diagnosis, but can you describe the imaging? Yeah, I think the exam goes well. Like
It's a long exam, a long day actually,
yeah.
but it will be fine, inshallah.
And
Yeah, for the test, the credit test, please share your questions because you only have one attempt and you actually don't know the exact answer. And every person has a different set of questions.
sometimes
Yeah, sometimes different set of questions. So share them. There is a compiled, I think you'll find in Dropbox one compiled that was made by Baria, Vanessa, and Varsha, Mersini. You'll all find it there. It's like, I think it's a collection of our years, like questions. It's all there. So again, according to your, also for you, if you have newer set of questions, please put them all together so that you can at least know.
And yeah,
Lina, is there anything else to add?
No, you actually said everything, so
okay.
Guys, if you have any questions, you can ask us at any time. And yeah, I think
That's it.
that's all. Thank you for joining.
And
guys,
thank
Good
you.
luck. Good luck with the exam.
Good luck for your examinations.
good luck. Ah, ta-da!